Hello and welcome. Today we're going to discuss ascites, which is an abnormal buildup of fluid in the peritoneal cavity. It is an important clinical sign, most often linked to chronic liver disease, but it can also result from conditions like heart failure, cancer, infection, or pancreatic disorders. Remember, ascites is not a disease itself, but a sign or a symptom of something deeper. In this session, we will cover why ascites develops, how to recognize and confirm it, as well as key management strategies. If you find this helpful, don't forget to subscribe and turn on notifications so that you can stay updated with more medical lectures. All right, so here we will take a brief look at ascites due to an increased hydrostatic pressure. Don't worry, we'll keep it simple and easy to follow. Think of it as tracing a pathway starting from the heart, moving through the liver, okay? Following the veins along the way. The first stop certainly is going to be the heart. When the heart struggles, like in cardiac failure, there is a decline in cardiac output, or in constrictive pericarditis, it increases venous pressure. That backlog of pressure eventually pushes fluid into the abdomen, giving rise to ascites. So the heart is one of the areas to look at when evaluating for ascites. Now let's move into the liver. And the most common is sinusoidal ascites, events that is occurring directly inside the liver, and it is usually from cirrhosis. This is the leading cause we see in clinical practice and should obviously be one of the first conditions to consider again when evaluating ascites. The next, we're just going to take a look at right above the liver. We see structures as the inferior vena cava and the hepatic veins. So obstruction in these structures can also lead to ascites, and specifically we're going to consider these areas as post-sinusoidal obstruction. So obstruction in the hepatic veins, as in Budd-Chiari syndrome, and hepatic venule obstructions can also lead to ascites. So think of it as a traffic jam in the major exit routes of the liver. Finally, below the liver, right there at the portal vein level, we have the pre-sinusoidal ascites. This can happen with portal vein thrombosis or even in parasitic conditions such as schistosomiasis, which is a reminder that global health conditions can also present in our clinics too. All right, now we take the next step. So whether the resistance we just talked about begins in the heart or in the liver as in hepatic obstruction, the end result is still the same: elevated venous pressure. And elevated venous pressure means elevated hydrostatic pressure within the splanchnic capillaries. Okay? Think of it as water pipes under too much pressure. The fluid has to go somewhere, and in this case, it leaks into the peritoneal cavity as ascites. There are two important outcomes to remember, one of them being portal hypertension, so take note of this. Now, regardless of the cause, whether cardiac or venous outflow obstruction, I repeat, when resistance is sustained, the portal venous system is exposed to excessive pressure, leading to portal hypertension from the elevated hydrostatic pressure. For example, in cirrhosis, which you know as the most common underlying cause of ascites, the fibrosis and regenerative nodules create architectural distortion that increases resistance to portal blood flow, and over time, portal hypertension develops. The body then responds by releasing nitric oxides, as well as pro inflammatory mediators, which cause splanchnic arteriolar vasodilation. Okay, so you would think vasodilation should help because there is vasodilation, which is going to increase flow. But instead of relieving the problem, this increases blood inflow into an already congested system, okay, which worsens the pressure elevation and the fluid leakage into the abdomen. Even though portosystemic collaterals may form, they cannot adequately reduce portal pressure in the setting of this persistent vasodilation. Furthermore, it's important that the excessive pressure can even promote bacterial translocation into the peritoneal cavity, leading to complications such as spontaneous bacterial peritonitis. Okay, so what exactly do we mean by portal hypertension? What is portal hypertension? All right, so uh, normal portal venous pressure is around 5 to 10 millimeter mercury. Okay, there is another term which is, I would write that here, which is hepatic venous pressure gradient. This one should be less than 5 millimeter mercury. So when this parameter here is greater than 6 millimeter mercury, this is what defines portal hypertension. So when HVPG is greater than 6, I repeat, this is portal hypertension. And it's not a secret, hepatic venous pressure gradient correlates well with the development of complications, particularly esophageal varices and variceal hemorrhage. So, importantly, maintaining the HVPG less than 10 millimeter mercury has been shown to prevent variceal hemorrhage. So, at the same time, apart from the portal hypertension, the excessive hydrostatic pressure promotes fluid filtration from the splanchnic capillaries, as already mentioned. This reduces the effective circulating volume. Okay. And obviously, you know what that means. The body perceives this as a low volume and compensates by activating the renin angiotensin aldosterone system, which obviously would lead to sodium water retention. There is also going to be an activation of the sympathetic nervous system, which can all further worsen ascites. As previously mentioned, ascites is the accumulation of fluid in the abdominal cavity. Normally, fluid is kept in balance by two main forces, and we just discussed hydrostatic pressure, which is like water pressure in pipes pushing fluid outward. Now, let's discuss oncotic pressure, which is like a sponge inside the vessels pulling fluid back in. This sponge effect is mainly created by a protein called albumin, which is produced by the liver. So here's where problems begin: albumin production. In chronic liver disease such as cirrhosis, the liver cannot make enough albumin. It is like the sponge effect inside the vessel is shrinking. There is less pull to keep fluid in the vessels. Next is albumin loss. In conditions like nephrotic syndrome, the kidneys leak albumin into urine. Again, the sponge effect here is being drained away, right? Then protein intake. So in severe malnutrition or starvation, the body does not get enough raw materials to make albumin. The sponge effect here never fills up properly. So when oncotic pressure falls, okay, um, fluid is less likely to be reabsorbed back into circulation. This leads to a reduced effective circulating volume. Okay, and in other words, even if the body has fluid, the circulation feels empty. We are emphasizing on the circulating volume. The body turns on the renin angiotensin aldosterone system, the RAS, and you can think of that as the house's emergency water saving mode. It tells the kidneys to hold on to salt and water, but instead of fixing the problem, this extra retention makes fluid accumulation worse, fueling the ascites. So ascites is not just about fluid being pushed uh, out by pressure in the veins. It's also very much about the loss of albumin sponge effect, whether from liver disease or loss through the kidneys or lack of dietary proteins. So it's not only pressure and albumin that matters, but sometimes the capillaries themselves become leaky. In conditions like tuberculosis infection or malignancies, the walls of the blood vessels are inflamed or damaged. Now, think of it like a garden hose, which is full of tiny holes. The water seeps out even when the pressure is normal. This leakage allows proteins and fluid to escape into the abdominal cavity, which results in the disruption of the normal balance of fluid exchange and accumulation of ascites. So, evaluating ascites goes beyond one or two checks, but for simplicity, let's use the word ascites right here as a guide. Think of it like a roadmap helping you not to miss key clues. So A right there stands for albumin, and you ask yourself, production, is there a liver disease? Loss, is there nephrotic syndrome? Or intake, is there malnutrition or starvation? So you would like to order a liver function test, renal function test, or urinalysis. Next, we'll take a look at systemic symptoms such as weight loss, fever, and night sweats. They can actually implicate a malignancy, infection, or connective tissue disorders. These are actually red flags waving along the road. You need to note that. And C, you're thinking of cardiac impairments, heart failure, constrictive pericarditis. If you see a chylous ascites, think of it as a milky lymphatic fluid, and connective tissue disease such as systemic lupus erythematosus can also be the case. Next, you take a look at I, which implies inflammation, infection, as well as intestinal issues. So here we are thinking of pancreatitis, pseudocyst, tuberculosis, peritonitis, or intestinal issues as in obstruction with distension that comes sometimes with ascites. Think of T as tumors, very important. These are red signs. So ovarian malignancy, especially Make syndrome, is a triad of ascites, pleural effusion, and a benign ovarian tumor. Other tumors may include colon, gastric, liver, breast, and lymphomas. E is for endocrine, and so you would like to have a thyroid function test. Here I mean myxedema, because it can also cause ascites. And think about encephalopathy, so look for confusion and hysteresis. And finally, S is for signs of chronic liver disease, so spider angiomata, caput medusa, averted umbilicus, hemorrhoids, Dupuytren's contracture, gynecomastia, and leukonychia may all be things you may find. When a patient presents with ascites, one of the most important diagnostic steps is paracentesis, removing and analyzing a small sample of the fluid. Think of it as interviewing the fluid to find out why it is there. So these are the key tests and what they tell us: albumin levels. And here I want to emphasize on serum, ascites, albumin gradient. Okay, we measure albumin in the acidic fluid and albumin in the serum. Then we calculate this parameter right here. So serum ascites albumin gradient is actually equal to serum albumin minus acidic albumin. Okay, that's very important. This ratio helps us determine where the problem lies. So, for example, if serum ascites albumin gradient is greater than 1.1, this is actually a portal hypertension related case. There is high pressure pushing fluid out of vessels. And if this is less than 1.1, this is a non-portal hypertension causes. So think of serum ascites albumin gradient as a pressure meter. High pressure means pressure-driven fluid. Other important tests would include the cell count and differentials. There is also gram stain with culture and cytology, which will help look for malignant cells. You would also like to find the glucose levels, lactate dehydrogenase, amylase, and triglyceride levels. If very high, could suggest chylous ascites, for example, if it is beyond 200 milligram per deciliter. So paracentesis is both diagnostic and guiding. It tells you if the ascites is due to pressure, that is portal hypertension. Okay, always remember the story of ascites begins with the fluid. Now here, I want to take a closer look at the acidic fluid cell count with you and what the numbers tell us, right? When you do a diagnostic paracentesis, one of the first things to check is the cell count and differential. So if absolute neutrophil count is greater than 250 cells per cubic millimeter, think infection. Most likely it is a spontaneous bacterial peritonitis. If the cell count is beyond 250 cells per cubic millimeter, but lymphocytes predominates, then you are thinking a tuberculosis or a malignancy, for example. Now we can take a further look at the evaluation, and beyond paracentesis, a full evaluation helps identify the underlying cause. So you want to take a look at complete blood count, check for infection, anemia, and even clues for malignancies. Renal function tests would help assess kidney involvement, liver function tests, and pancreatic enzymes such as amylase and lipase for pancreatic related ascites. Let's also talk about infectious workup. And here specifically, I want to talk about tuberculosis if there is a suspicion. So we are talking about a purified protein derivative test, PPD, or tuberculin skin test, acid fast bacillus, stain and culture, gene expert for rapid TB detection. Imaging is also very important. Ultrasound, CT scan, and MRI may help evaluate for tumors, obstruction, or structural changes. And laparoscopy with biopsy may be indispensable for diagnosing malignancy or tuberculous peritonitis. So, ascites is a sign or a symptom, not a diagnosis. Always search for the story behind the fluid. Management of ascites. Here we're going to emphasize on the big picture. The golden rule in ascites management is pretty straightforward. Treat the cause and not just the fluid. Example, every effort must be made to treat liver disease, heart failure, infection, malignancies, tuberculosis, or thyroid disorders, for example. Therapeutic paracentesis. Usually, this is for TENS or symptomatic ascites to relieve discomfort and breathing difficulties. Albumin infusion helps prevent circulatory dysfunction and renal impairments. Often, this will depend on the amount of fluid which is removed. So, for example, if you are removing about 4 to 5 liters, it will be advisable to infuse albumin. Reduce portal hypertension. So, factors such as salt restriction, diuretics, spironolactone furosemide as used in chronic liver diseases, and also in acute variceal bleeding, somatostatin analogs are also used. You want to monitor the weight, electrolytes, and renal function regularly. Again, you want to prevent or manage complications such as infections, so you watch out for spontaneous bacterial peritonitis, hypoglycemia, especially in liver diseases, hepatic encephalopathy, hemorrhage. You need to monitor for variceal bleeding as well. And in refractory ascites, if fluid keeps returning despite medical therapy, you would like to sometimes consult for a transjugular intrahepatic portal systemic shunt tips, which reduce portal pressure by creating a pathway between portal and systemic circulation. Liver transplantation is also used in end stage liver diseases, for example. Thank you, and I hope this was useful. If you enjoyed it, then hit the like button and subscribe to the channel. Bye.